Thanks for being here. Welcome to scientific session number 15. This is CDH and ECMO. I am completely impressed by the number of people that are here at 4 o'clock on Friday. This is fantastic. We really appreciate everyone's support. My name is Mike Dingeldein. I am the division chief at Rainbow Babies in Cleveland.
And my name is Rachael Sundland. I'm finishing my chief year at Maimonides in Brooklyn, and we'll be joining the Michigan crew for their surgical critical care coming up in August.
Just a gentle reminder for those of you that are scoring to please complete your evaluations no later than 5:30. And just a reminder, we have 5 minutes for presentations and 3 for questions, and we will stick to that. Thank you. First up, we have Dr. Felix D. Bree, a general surgery resident from the Children's Hospital of Philadelphia, presenting Recurrence after surgical congenital diaphragmatic hernia repair, a large 10-year single center review.
Thank you. Thank you for this opportunity to present. I'm a general surgery resident at Duke, but I'm presenting the 10-year recurrence data from the Children's Hospital of Philadelphia. So why did we do this research and why it's important? Recurrence is actually a common complication which can go paired with severe morbidity, but also in the worst cases also mortality. High quality data is available for short term, mostly in-hospital recurrence rates, but long-term data is lacking. And so our group in 2012 reported on 150 patients with a median follow-up of 1.5 years. Recurrence rates then were very low, 4% and 5% for primary and patch repairs. And so just recently, the CDH study group reported a fantastic paper reporting on 297 patients with a median follow-up of 2 years. And the recurrence rates they reported were 9.8 and 13% for patch repair. So we just wanted to check in on how things stand now 13 years later. So we did a retrospective review of at the CHOP institution, looking at posterolateral CDHs repaired between 2013 and 2023. We excluded contrails pathology infants and then also associated omphalocele, kids with an associated omphalocele. 3 operative techniques were used. So the primary repair, 7% were done thoracoscopically, and then we had patch repairs using PTFE, and then the last one is a flap repair, it's a transversalis flap repair. Now, this graph portrays the different operative techniques used over time. And as you can see, in 2021, there's an inflection point where our technique changed from patch repair to muscle flap repair. So looking at the primary repair group, 174 patients included. 2/3 had a prenatal diagnosis, 23% liver up, no C or D type defects, and ECMO in 4% of those patients. If we look at the patch repair group, almost all patients had prenatal diagnosis. A large majority had liver herniation. 68% were either a C or a D type defect, and 35% use of ECMO in those infants. Intuitively, a much more severe phenotype than the primary repair group. If we then look at the muscle flap group, we see that almost all patients had a prenatal diagnosis. 81% had liver up, 77 C or D type defect, and then ECMO was deployed in 30% of those patients. If we compare the patch and the muscle flap group, there were no differences between those groups. In terms of recurrence, we have 2.6 years of median follow-up. 31 patients recurred, and the median time to recurrence was a little over 1.5 years, 19.5 months. And for the primary repair group, we had a median follow-up of 2 years. The recurrence rate was 3.4%, and the time to recurrence was 7 months. None of the thoracoscopically repaired patients had a recurrence. The patch group, we had a much longer follow-up, around 4 years, and then the recurrence rate was also higher, 11.7%, and the median time to recurrence was about 2 years. If we then look at the muscle flap group, we have only 1 year of follow-up, and then we have a recurrence rate of 4%, and then the time to recurrence is about 2 years. So if you compare the patch and the muscle flap group, we have a much shorter follow-up, but although the recurrence rate trends lower, there was no statistical significance. If we then look at the time to recurrence, which is portrayed on this graph, we have the probability of recurrence over time for the different repair types. We see that that there's no statistical difference between those groups. So in conclusion, we have we here report the largest single institution cohort of patients with longer term follow-up for the CDH repairs. In 21, we changed our practice from patch to muscle flap repair for the more severe CDH phenotypes. And then the recurrence rates we observed for the muscle flap repair were similar to the primary repair and trend lower than the patch repair, although without statistical significance. But the time to the recurrence, importantly, does not differ among those groups. The main limitation we have in this study, however, is the unequal length of follow-up, with the muscle flap repair being much shorter than the patch and the primary repair groups. And with that, I'd like to address some questions.
Great. Thank you. Great. Any questions from the audience? Just to start out, why did CHOP do the switch from patch to muscle flap?
Great question. So there was a bad run of patch infections, so that prompted the change. Yeah. So.
And didn't mention that. And for the muscle flaps, any
Right.
ventral hernia occurrences?
Not that I'm aware of, but yeah, that's something we should definitely look into. Yeah.
Great presentation. I think you mentioned thoracoscopically you had no recurrence. So I had 2 questions on that. One, did you do any patch closures thoracoscopically? And then second question, if you did it primary, in the early days of thoracoscopic repair, the rate of recurrence was actually higher. So what technique was used to get 0 recurrence in the thoracoscopic approach?
Right. I think for your first question about the patch repairs were all done open. And then your second question, could you repeat that, please?
Second question is, what was the surgical technique? So they were all primary repairs such that you got 0 recurrence rate? Because the early experience for most people, and certainly across the country, was a slightly higher recurrence rate when done thoracoscopically. In other words, did you use any mesh underlay? Was any other adjuncts to the technical repair?
I don't think so. One thing I will say is the large majority is done open. Even primary repairs were done. It's a very small subset of the primaries. I'm not answering your question, but the change in technique, I wouldn't be able to answer that. I'm sorry.
Thank you.
Yeah.
Hi, great talk, Alex Gibbons, fellow at Phoenix Children's. Just a question, obviously the focus for this talk was recurrence rate, but in terms of other complications, did you notice like an increased bleeding rate at all for the muscle flap, particularly for the patients who are on ECMO?
Yeah, we didn't look into, I don't have that data here, but so it's definitely something we should look into. So that with the ventral hernias, yeah. May I ask one question to the audience?
Sure.
Yeah. Who is doing CDH repairs? Who of you? So show of hands, maybe. Yeah. Okay. And who does muscle flaps? Yeah. Okay. Yeah. It's good. It's good. I hope we sparked some interest with this report. Yeah.
All right. Thank you.
Okay, our next presentation is going to be novel Napsin A protein expression in congenital diaphragmatic hernia, presented by Dr. Kylie Holden, coming from the University of Texas system.
Hello, good afternoon. Thank you for the opportunity to present our work. CDH, or congenital diaphragmatic hernia's abnormal anatomy, can be detected typically in a routine ultrasound imaging about 20 weeks gestation. If it's identified, specific ultrasound measurements can be taken to help assess the disease severity. One of the most important and most commonly used measurements is the observed to expected lung to head ratio, or the O to E LHR. This measures the size of the good lung, or the lung on the opposite side of the defect, at the level of the four-chamber heart and compares it to the size of the head. This observed ratio is then compared to what's expected for their gestational age. Values are assigned as a percentage and have been shown to correlate with postnatal diaphragm defect size, thus being proven to provide an in utero risk stratification. Larger O to E LHR values, values above 45%, are typically correlated with smaller, lower-risk defects, while values below 25% are typically associated with larger, higher-risk defects. It's important to note, however, that this is not an exact science, and severity is not always accurately predicted. The frustration with this prenatal variation in accuracy is what drove the conceptualization of this project. We wanted to develop a non-invasive test that would allow for not only earlier identification of CDH, but a more consistent risk stratification method. We based our approach on the concept of fetal exosomes. While we've heard other excellent presentations that have showed a variety of other ways to potentially detect CDH, we chose fetal exosomes as they're vesicles that circulate in the mom, but carry disease markers specific for the baby. These exosomes can be purified from maternal fluid samples and provide valuable disease-specific information about a fetus. If we can identify a protein specific to the pulmonary hypoplasia seen in CDH, we theoretically could isolate fetal exosomes from maternal fluid samples and establish a new, reliable, and reproducible detection test for CDH. However, currently there is no known protein or genetic link to CDH, so for our lab, the first step in this process was to identify that novel protein. We did this by testing several different potentially pulmonary markers, but found that Napsin A, which is an aspartic peptidase that is unique to fetal lung development and is responsible for processing pulmonary surfactant B, to be the most promising. The aim of the study was to assess the expression of Napsin A in human amniotic fluid exosomes for patients with CDH, and to determine if this protein could serve as a potential marker for a non-invasive disease detection. We used previously banked amniotic fluid samples from both control patients and CDH patients. Fetal exosomes were isolated from the amniotic fluid using a well-established protocol. These exosomes were tested on several Western blots to examine each of the target proteins across all patient samples. Protein levels were compared to beta-actin loading controls and quantified using image-J technology. After Napsin A was selected from amniotic fluids, we used fetal rat pulmonary tissue for validation. The first step in this process was to confirm that Napsin was the best potential target protein by comparing it to several other pulmonary markers. Now, these are very real and raw Western blots that we use for our initial protein detection. In these images, the bottom section provides a loading control for reference, and as you can see, Napsin is found to be consistently elevated in protein levels for CDH patients compared to the controls. After zeroing in on Napsin, we then aimed to confirm that it could be consistently found across different patients. Again, we found that Napsin was in more CDH patients than compared to the controls. Finally, we confirmed its consistency by repeating the patient samples. Again, the bottom represents the loading control, the right of the red bar represents the CDH patients, and to the left represents the controls. By repeating these patient samples, we confirmed that this protein and method are consistent and reproducible. For the formal analysis, we wanted to quantify exactly how much Napsin was found in each sample. We established this mean quantification by comparing Western blot line density of Napsin to the level of the loading control. In this Western blot, you can clearly see how much thicker and darker the CDH band is compared to the controls. Their mean quantification values confirm this. The quantification value for the control protein was found to have a relative intensity of 1.0, and the CDH patient had a mean relative intensity of 2.4. This is a twofold increase of Napsin levels compared to CDH samples, or compared to the control samples, with a significance of 0.08. Next, we wanted to confirm that Napsin could be used in the rodent model, and to see if this was something that we could reliably test in a translational method. We found that rodent tissue echoed the findings of our amniotic fluid. Again, Western blot lines show much thicker and darker bands for the CDH patients compared to the controls. And when looking at the mean quantification values, the control protein had a relative intensity of 0.47, and the CDH patients had a 0.83, a clearly significant difference. So what can we conclude from this? One, that Napsin is elevated in both fetal rat tissue and human amniotic fluid, making this a promising marker for both investigative and translational work. Two, that Napsin may be a novel protein linked to CDH. And three, that identification of this protein may facilitate the development of a non-invasive diagnostic test for CDH in the future. Thank you.
Great presentation, Kylie.
Thank you.
And congrats, as usual, great work from Dr. Harting's lab. Question for you is, how do you know where these vesicles coming from, the exosomes? You're taking them from the amniotic fluid. Napsin is expressed also by kidneys. But beyond that, I mean, how do you know that the vesicles are really truly from the lungs and not from other organs?
I mean, for our testing, we don't. It could technically be from the kidneys, but we do know that this marker is unique to fetal lung tissue developing in the baby. In addition, it's specific for the surfactant B protein. And when we find it in the amniotic fluid, the amniotic fluid the babies are breathing in and out, so I would like to assume that most of it is from the lung, but we could do another test further to try to sparse out whether it's kidney or not.
Yeah, I think it's important because, in fact, it can also be from the kidney, but it could be, it's not easy to immunocapture the vesicles and know where they're coming from, but it's doable. So we can talk afterwards.
Please.
Great study. I was just noticing on the quantification of your Western blots that about half of your specimens were down at the level of controls. So it's not surprising that there's a lot of variation since you're using human samples. But did any of that variation correlate with the severity of CDH, or the ones that were more like controls, the mild CDH? Because certainly in the animal model where things are more consistently severe, you saw
More consistency.
for all of them.
So right now, most of the samples that we have come from previous patients that have had amnios done for likely feto. And so most of the patients have severe CDH. The next step in this is to be able to parse out to see who has the lower risk and who has the higher risk. Most of our samples are high risk patients because of the way that we're collecting the fluid. But that would be a really good thing to study next.
So then if they are all higher risk patients, what would you conclude about the sensitivity
The variability.
test for diagnosing or predicting severity of CDH, or however you might envision using it?
I think amniotic fluid is very difficult because it can be very dilute. It's very diverse. It has it's a dirty fluid sample that we're collecting. The goal of this, or the ultimate thing we would like to accomplish, is to be able to study this take this from a blood test. And hopefully there we would have a lot more clean data and we would be able to risk stratify a lot better rather than amniotic fluid.
Thank you.
Thank you.
Just a reminder when you come up to ask questions to please say your name and where you're from. Our next speaker is Dr. Wu, Pediatric Surgery Research Fellow from Columbia University, Morgan Stanley Children's Hospital, presenting evaluation of timing of repair of congenital diaphragmatic hernia in premature infants.
Hello, everyone. Good afternoon. Thank you for this opportunity to share our work. So we have no disclosures. We did this research to understand how timing of CDH repair in patients born prematurely affects outcomes. This study is important because it can help improve care and overall outcomes in premature infants with CDH as we work to optimize clinical decision-making on the timing of CDH repair in the subcohort of complex CDH patients. So briefly, overall survival in all infants born with CDH is about 65 to 80% versus just 50% in premature infants. Timing of repair is controversial in this patient population. Proponents of earlier repair suggest that it can decrease time on the ventilator and subsequent risk of barotrauma, and it can allow for earlier initiation of feeds and decreased length of stay. Those who propose delaying repair suggest improved pulmonary reserve, feasibility of ECMO cannulation with increased vessel size and decreased risk of intraventricular hemorrhage, and improved tissue quality to allow for a more robust repair. Thus, we hypothesize that delaying repair of CDH in infants born prematurely is associated with improved mortality and morbidity when compared to earlier repair. So we conducted a retrospective cohort study of CDH study group registry patients from 2015 to 2024. This is an international registry of patients from almost 100 centers. Prematurity was defined as less than 37 weeks of gestational age at birth, and our primary outcome was survival to discharge. To determine our study cohorts, we initially performed a cubic spline analysis to assess the nature of the relationship between gestational age at repair and survival probability, inverse probability of treatment waiting, permitting us to control for inhaled nitric oxide use and ECMO requirement, which can confound timing of repair, allowed us to then compare baseline demographics, operative details, and outcomes between more balanced cohorts. Then multivariable regression models were used to quantify the association between gestational age at repair and survival probability to discharge. So this is our initial cubic spline analysis in premature infants. As you can see, the relationship between gestational age at repair and predicted survival probability is actually not linear. So at about 32 weeks of gestational age, survival probability begins to plateau and almost approximate that of term infants, in which we actually do not see a relationship between gestational age at time of repair and predicted survival probability, as shown by the flat line. So using this information of the 5,000 patients, almost 5,000 patients from the CDH study group registry, we narrowed it down to 1,143 premature infants, of which 857 underwent repair. We then compared those who underwent repair at less than 32 weeks of gestational age and those who underwent repair at greater than 32 weeks of gestational age based off of our cubic spline analysis. And the comparison of the outcomes are shown in this table below. Those that were repaired at less than 32 weeks of gestational age, there was not a decreased time on the ventilator, decreased length of stay post-CDH repair, or decreased time to full PO feeds. Postoperative complications and recurrence were similar between the two cohorts. However, those that were repaired at less than 32 weeks of gestational age had significantly higher rates of abnormal head imaging and significantly decreased survival to discharge. A multivariable regression analysis where we adjusted for inhaled nitric oxide use and ECMO requirement, gestational age at repair at less than 32 weeks was associated with 68% lower odds of survival to discharge. And when we compared when we analyzed those that were repaired at less than 32 weeks, for each incremental 1-week increase in gestational age at repair, it was actually associated with 3 times increased odds of survival to discharge. So in summary, CDH repair at less than 32 weeks is associated with increased rates of abnormal head imaging and decreased survival. CDH repair after 32 weeks is not associated with increased time on the ventilator, longer length of stay, or increased time to full PO feeds. So what we can conclude then is in premature infants, perhaps delaying repair of CDH until after 32 weeks of corrected gestational age may be associated with improved neurologic outcomes and survival. Thank you for your time and attention, and happy to take any questions.
Great presentation. It's not easy, and I know that, of course, this is a database, and your statement is quite strong at the end. And of course, you may be a baby born at 31 weeks of gestation, and you need to wait just for a week, or you are born at 26, 27. Did you do any sub-analysis in the group less than 32 and looking at the number of babies that you had and how they were doing? Because of course, if you wait, again, if you're born at 26, you may wait for a month and a half, according to what your statement is in your conclusions.
Yes, so this study was very difficult. If you guys read the abstract, there is some differences. So based on this retrospective, and there's not many patients that are born premature. As you can see, we only had 41 samples, patients that were born or repaired less than 32 weeks of gestational age. We weren't really able to parse out the effect of prematurity on outcomes and delaying repair. But when we assessed, I actually have that data. So when we are actually looking at age at day of repair of those who underwent repair at less than 32 weeks, it actually was similar to those who were repaired at greater than 32 weeks. They only waited about a median of 4 days in those who underwent repair at less than 32 weeks of gestational age.
So how many did you have that were less than 28?
Those that were less than 28.
So effectively, you can talk with any neonatologist. Anything that is any baby that is beyond the 28 weeks mark, it's going to do okay. Mm-hmm. Less than 28, and there's many babies, especially now with fetal around, that actually are born severely premature.
Mm-hmm. That's
and
a very good
then the
point.
question still stands. What should we do with these babies? Wait longer, or not? Technically, I think we can all repair babies that it might be a little bit more challenging. It's like, is it the right time for the baby?
Yeah, I think our idea was in those that we can wait, but based off of this data, we probably only have less than 15 patients who are less than 28 weeks of gestational age.
Okay, thank you.
I'll make my question quick. Megan Fuller, Children's Omaha. Did you have any age-matched controls by gestational age in terms of neurologic outcomes, knowing that we may have impaired neurologic outcomes in prematurity at baseline?
That's a very good
Studied.
question. So we tried to control for gestational age by actually using gestational age at time of repair, and that's how we did our analysis. But what I looked at was the actual baseline rate of abnormal imaging in these two populations are still higher than those compared to just preterm infants without CDH.
Tony Ferrantella from Atlanta. Were there patients that died prior to repair that maybe would have been considered in that delayed group had they, survived?
So this actually shows number of patients who actually underwent repair and those who didn't, and I guess those who didn't include those who died. But our question was more so in those who actually can make it to repair. So we did not study that population.
Thank you.
Thank you.
Okay, our next presenter is going to be Untold Stories, a qualitative investigation of patient and family experiences with congenital diaphragmatic hernia, presented to us by Dr. Alexandra Demmer from McGill University.
Hello, and thank you so much for the opportunity to present our work. We have no conflicts of interest to disclose. We conducted this research because the voices and perspectives of CDH patients are rarely heard along their illness journey. And we're presenting this research today because we believe that hearing the voices of our patients is critical in designing quality improvement initiatives which meet their unique needs. As we've heard, CDH infants suffer from multi-system morbidity in addition to the known cardiorespiratory effects of CDH, which can have long-lasting impacts on both the patient and their family, impacting quality of life. Structured multidisciplinary long-term surveillance is critical for the early identification and mitigation of this morbidity. And it's likely even more crucial for those infants with neurodevelopmental impairment, or NDI, for whom there are increased care needs. However, despite understanding the importance of these programs, little is known about the lived experiences of families from their own perspective and the efficacy of existing programs in meeting family support needs. The aims of this study were to explore the lived experience of CDH for patients and their primary caregivers, including those with NDI as determined by developmental pediatrician and Bailey assessment, and to explore the type and level of support that they desire and need from the clinical team and community resources. We anticipated that patients with CDH and NDI and their families would face greater challenges and have more difficult lived experiences compared with CDH children without NDI. We conducted a qualitative descriptive study of the lived experience of CDH patients and their primary caregivers followed in our CDH long-term health surveillance clinic. The research involved focus groups with participants grouped according to time availability, language preference, the presence of NDI, and clinic graduate status. And the focus group sessions were audio recorded, transcribed, translated into English when necessary, and then subsequently analyzed using an inductive thematic analysis. A total of 26 participants contributed narratives regarding their lived experience of CDH in one of 4 focus groups or 2 individual interviews. And this included 10 CDH children, 12 primary caregivers, 4 young adult clinic graduates. Thematic analysis revealed 4 primary themes, which will be presented with illustrative quotes in the subsequent slides. So theme 1 was experiencing CDH as a caregiver. Fear and anxiety were common, especially in the early periods surrounding diagnosis and birth. One parent recounted, psychologically having the fear of losing a child, it took weeks, months before not thinking about it anymore and being anxious at that level. Theme 2 was experiencing CDH as a child. A common narrative to emerge among the children interviewed was the lack of lasting impact of their diagnosis despite early challenges. One child stated, I don't have any problems. I can do sports, I run, that's it. My life is normal. For those children who had graduated from the clinic, transition of care provoked fear and uncertainty. However, most revealed a positive and relatively seamless transition. This was in contrast to parents who continued to express fear related to the transition process. and the ability of their child to access adult physicians with an understanding of their child's condition. Theme 3 was striving for normalcy. In terms of quality of life, both children and their primary caregivers expressed having an excellent quality of life despite early challenges. One parent shared, "In terms of quality of life, there's nothing really different. There's no special treatment. He's leading a life as normal as the others, although he's normal too so far." The last theme identified was getting the support we need. Many families expressed a desire to communicate with other families, stressing the importance of local support who could speak to the local context, as opposed to national or international online support forums. So putting it all together, our findings provide evidence that despite persistent morbidity, particularly among children with NDI, most children with CDH perceive themselves as having a high quality of life with minimal residual deficits. In contrast, parents tend to experience significant psychological distress, particularly during the early postnatal period and the transition to adult care. Despite general satisfaction with existing hospital and community resources, areas for improvement remain, including the need for enhanced parental support, including the ability to interact with other CDH families, and more structured transitional care processes that actively involve both children and their parents. The results of this study have suggested several areas for local QI initiatives, such as the development of local CDH family support network and the addition of regular quality of life assessments to our CDH follow-up visits so that we can better assess how quality of life changes across the life course. Lastly, our findings have paved the way for future research efforts, such as the development of more formalized transitional care processes, ensuring that both patients and their families are actively involved in this planning process. I'd like to take a moment to acknowledge our sources of funding and to thank my entire team. I'll take any questions now. Thank you.
This is really powerful and important work, so I appreciate you and your team going through this effort. I have two questions. One is, were any of the families or children ECMO survivors of CDH, and how might their interviews or experiences be different? And the second question is, there are some single-center and multi-center data that says that CDH survivors experience a lot of frequent rehospitalizations and ED visits within the first 2 years of life post-discharge. And did those themes come out? I was surprised to see that the one quote you said, "My life is normal." That's not what I expected based on other data.
Great questions. So I believe, looking back at our research, we had one ECMO survivor, and actually the work leading to this project, which is not presented today but was in a previous project, was actually a community consultation, which really drove the development of the questions that we asked in the focus groups, and that included a fetal survivor as well. And so while they may have expressed challenges along the way, and I think this is where the parental experience comes in, that they're continuing to express sort of that fear and anxiety, as the children start to grow and are presumably doing better than they may have been doing in their initial neonatal period, they're very quick to forget, those frequent hospital visits. And I think that's where the parents continuing to express that fear comes in. And that's why we saw that they continue to have fear when discussing transition of care, because that is still very present in their mind when they were thinking about, possibly losing a child and those hours spent in the NICU. And with regards to your second question, with frequent emergency room visits and things like that, again, that was something that we actually explored in a prior study, was the work that we presented last year, was that maybe our clinic is not doing the best job at actually meeting those needs, because we do still have a high incidence of ER visits and visits outside of the structure of the clinic. But ultimately, the families felt as though the clinic itself, when they went to it, was really providing excellent care. But there is a need for increased community resources, certainly.
I'll be quick. Matt Harding, Houston. Kudos to you for taking on the thing that most parents want to actually know that none of us can answer when they're sitting in front of us in the fetal center, right? We can talk about survival and risk stratification, all these other things, but this is what they want to know. What's my kid going to be like when they're 2 or 4 or 6 or 8? My question for you is, did you do any risk stratification? What was their CDHSG stage? What was anything else? Because an A defect should have a normal quality of life. And a D defect that has a perceived normal quality of life is great. They've either learned to face those challenges, or that's been normal, or they had amazing care and ended up doing well. But we've got to start to talk about this in terms of risk stratification.
It's a great question. Certainly, that was not the primary aim of the study in terms of trying to recruit. And as you may know from doing qualitative research, it can be very challenging to recruit a very diverse sample. So the initial aim of this was really to just try and recruit as many families as we could, both with NDI and without, and then also a graduate cohort. I can tell you that we did have patients with more severe defects, and that's where I think we saw that in the NDI group as well. But those numbers certainly need to be further explored, and I think we need to continue this work. Thank you.
Thank you.
Thank you. Our next presentation is by Dr. Michael Zabalik, the Pediatric Surgery Research Fellow at Riley Hospital for Children. The presentation is Crescent RA VV ECMO cannula, an analysis of associated cardiovascular injuries.
Thank you for the opportunity to present this talk. Doctors Keene and Gray serve as educational consultants for Medtronic, which is the manufacturer of the cannula. There was a significant decline in VV ECMO utilization in 2018, combined with a concurrent rise in VA ECMO utilization. And this was thought to be due to the discontinuation of the Origin cannula, which was a dual lumen right atrial cannula. Also, this was combined with the concerns that the bicaval dual lumen cannula had a significant rate of cardiovascular injury, up to 14% in the literature. In 2021, Medtronic came out with the Crescent RA cannula, which is now the only dual lumen right atrial cannula on the market. This is important because in VA ECMO, we know that there's an increased rate of neurological complications as well as an increased rate of mortality. So this, combined with the concern with injury with the bicaval cannula, led us to want to assess the incidence of and risk factors for cardiovascular injuries with the Crescent RA cannula. We conducted a multi-center retrospective study in 33 centers across the continental United States. We had 327 patients that were cannulated with the Crescent RA cannula over the course of 2 years, and our primary outcomes were cardiovascular injury and cannula-related mortality. The majority of our patients were male. Neonates were term. They were cannulated at about 4.5 months of age and weighed about 6 kilos. The survival to decannulation and discharge were 83% and 75% respectively. There was a 5.5% rate of possible cardiovascular injury. The reason I say possible is because we included truly detected cardiovascular injuries, as well as patients who may have had injuries due to significant pericardial effusions and cardiac tamponade that could not have been diagnosed otherwise. Those rates were 4% and 1.5% respectively. The rate of major perforation was 3.7%, and the rate of cannula-related death was about 1%. When looking at risk factors for cardiovascular injury, there was no difference between the injured and non-injured patients based on sex, neonatal status, day of life, weight, or cannula size. There was a difference between the groups based on cannulation method, but when broken down, this difference was between the open cut down versus modified percutaneous approach, and we did not feel that this was clinically significant. There was no difference between the groups based on difficulty advancing the cannula at the time of cannulation or lack of cannulation guidance. But there was a difference between them based on difficulty determining the cannula tip location on ultrasound, as well as cannula tip migration during the ECMO run. On multivariable logistic regression, when adjusting for neonatal status, weight, and cannulation method and cannula migration, there was cannula migration significantly affected cardiovascular injury with an odds ratio of 3.2. When looking at all 18 patients, looking at common themes for injury other than migration, inadequate sedation as well as cannulation without imaging guidance were also themes that popped up. You can scan the QR code to the left of your screen for a list of recommendations for cannulation and cannula position monitoring from one of our previous publications. The limitations of our study are obviously its retrospective nature, the small sample size, although I'll say this is probably one of the largest studies in terms of this type of study, the limited detail due to the multi-center study, as well as voluntary participation by sites, so some patients may have been missed. So in conclusion, there's an approximately 4% rate of serious cardiovascular injury with use of this cannula. In cardiovascular injury is 3 times more likely if there's migration of the cannula. There's a 1% rate of cannula-related death, And other common themes in injured patients include lack of imaging guidance as well as inadequate sedation. And most importantly, we feel that education regarding cannulation and cannula position monitoring in centers that are adopting the use of this cannula are important to decrease the rate of injury in the future. I'd like to thank the following people, especially my mentor, Dr. Brian Gray, for their support during this research.
Promote Poliganla, Montreal. Thank you. Very nice talk, very nicely presented. Just a question, the way I look at it is sort of in two phases in terms of perforation. There's the perforation and the complication that happens at the time of catheter insertion, and then there's the complication of perforation that can happen with migration and ongoing care. And I was wondering if you're able to tease out any trends at all with respect to that in your data.
Yes, so at the time of cannulation, of those 18 injuries, 17% occurred at the time of cannulation. About 28% occurred within a 24-hour window, 17% within between 24 and 48 hours, and then 39% were after 48 hours. So a majority of them were after 48 hours.
Mike, that was a great presentation, and I think work Dr. Gray has done in this area. I think it's just important for all of us to recognize that ECMO is a dynamic process, and not just for the double lumen crescent cannula, but we need to be vigilant about cannula position during the ECMO run for a lot of physiologic reasons. So, I mean, I applaud the work in this area, but also just the education that we need to think about that for all of our ECMO cannulas.
Yeah, thank you very much. I 100% agree with the vigilance about the cannula position throughout the run. Thank you, Dr. Mihalishka.
Was there any data looking at the volume of cannulas being placed by hospitals and the error rates?
I did not look at that data. I was a little bit worried about looking at that and potentially, red flagging any particular institution.
Kevin Johnson at Vanderbilt. Do you have any theories about whether this is an issue of fixation of the cannula? Is this a technique that we need to be doing something different to hold this in place? Is this a vigilance in monitoring cannula position like Dr. Maflisha had brought up? From
what I gather, I think the most important thing is cannula vigilance and monitoring. I think, for example, the one patient that really struck me is that the cannula was deep for approximately 7 or 8 days, and the patient then suffered a death afterwards, and that was known, but it was ignored.
Thank you.
Thank you.
Our next speaker is going to be talking to us about ionizable lipid nanoparticles for gene editing of the fetal lung. This is Dr. Adele Riccardi, a postdoctoral research fellow coming to us from Children's Hospital of Philadelphia.
Thank you, everyone. Although I'm not speaking about CDH or ECMO, I am excited to tell you about some of our work on developing novel lipid nanoparticles for gene editing of the fetal lung with the eventual goal of treating cystic fibrosis prior to birth. So we can now diagnose many genetic disorders early during pregnancy, and early diagnosis allows for the possibility of early intervention. And in diseases such as cystic fibrosis, there are signs of multi-organ pathology affecting the functioning of the respiratory, the gastrointestinal, and the reproductive tract already present at the time of birth. Thus, the overall hypothesis of our work is that prenatal intervention with in utero CRISPR-mediated gene editing could correct disease-causing CF mutations during the initial stages of pathogenesis, and that this correction could potentially allow for normal organ development, functional disease improvement, or perhaps even cure. We can deliver CRISPR components using lipid nanoparticles via systemic delivery through the vitelline vein. However, when we do so, we see very robust mRNA delivery to the fetal liver and less so to organs such as the lung and the gut, which are the organs affected by cystic fibrosis. Lipid nanoparticles are typically made of 4 components, and each of these is responsible for a different property of the LNP formulation. It's the ionizable lipid component that confers the tissue specificity of the nanoparticle, so thus we are interested in seeing if we could find novel ionizable lipids that could be used to deliver mRNA and CRISPR components to the fetal lung. So I'm lucky enough to also work within the engineering department at Penn, where we have been able to design many different novel lipid groups or lipid classes that have unique head groups or tail structures or biodegradable properties. And these have unique or enhanced properties in vivo, such as better transfection of the liver, some show tropism to the adult lung, and some have enhanced endosomal escape, which results in increased mRNA delivery. So I constructed a unique library using some of the novel lipids that we had synthesized. So using this library, we formulated a library of lipid nanoparticles containing a luciferase mRNA, and this allows us to measure light when we deliver this systemically in utero and allow us to see the measure of transfection of the different organs of interest. So after we delivered our lipid nanoparticle library to mid-gestation mouse fetuses on E15, we waited 4 hours and dissected multiple fetal organs and then measured the amount of light expressed in each tissue. So here's all of the data from this large screen, and focusing specifically on the lung, we were able to identify multiple formulations that were capable of delivering mRNA efficiently to the developing fetal lung. Interestingly, when we look at how these lipid nanoparticles perform in fetuses and adults, we see very different tropism or distribution of the mRNA to different organs. So it isn't enough just to assume that if this works in an adult and goes to the lung in the adult, it's also going to work for the fetus. We were next interested in seeing what level of modification we were able to see in multiple organs within the fetus. For these experiments, we used a Cree mouse model where delivery of a Cree recombinase RNA results in removal of a stop codon upstream of a GFP gene. What this allows us to do is to use GFP expression as a measure of gene modification. So for this, we delivered our lead formulations to both fetal and adult mice, and then after 30 days, harvested 10 different organs, and then used flow cytometry to look at the percent of gene modification. So as expected, when we deliver these LNPs to adults, we see very high levels of modification within the liver. But interestingly, in the fetus, we're also able to modify the heart, the lung, the kidney, and for some formulations, even the pancreas and the bone marrow, which are organs that are really typically difficult to reach in adult animals. Again, focusing specifically on the lung, we see around 30% modification using our lead formulations after delivery to the fetus. And all of these formulations perform better than when we deliver them to adults. Here are some representative confocal images of our lipid nanoparticles delivering to the lung, and we focus on this A3 formulation here, which is in the second column. Again, we see little modification, if none, of the adult lung, and we see robust modification all throughout the fetal lung. We were next interested in seeing what specific cell types we're able to modify within the fetal lung, so here we performed the same experiment with our LOX-CREAM model and then sorted for specific cell types of interest within the lung. So in addition to the endothelial cells that you would expect to modify after a systemic delivery, we also found that we were able to modify around 20% of the epithelial cells and the basal cells, which are the stem cells of interest in some stem cells in the lung, and these are both the the cells of interest for the treatment of cystic fibrosis. And lastly, we were interested in seeing if we could use our lead formulations to correct a disease-causing CF mutation in human airway cells. So for this, we looked at 2 different base editor formulations as well as 2 different guide RNAs. And both of the combinations of base editor and guide RNA resulted in the same levels of on-target gene correction. However, one of these combinations resulted in a high level of bystander modification, which is correction of an adenine that is not intended to be corrected within the editing window. However, one of the formulations depicted here in blue on the right, this guide RNA and base editor combination had a very favorable ratio of on-target to bystander editing. So in conclusion, we were able to identify some novel ionizable lipid formulations that were capable of delivering RNA to the fetal lung. These resulted in clinically relevant levels of modification within the lung and cell types affected by CF, and we could use our lead formulations to correct or base edit a disease-causing CF mutation in human airway cells. Our ongoing work is working on using these formulations to correct this mutation in the fetal mouse lung, and we're also working on optimizing formulations and delivery routes to reach other organs affected by CF. I'd like to thank my labs, the people in the lab that help with this work, as well as our collaborators, and I'm happy to take any questions. Thank you.
Hey, Matt Harding from Houston. Really elegant work that you and the Pronto Lab are pursuing here. I have 2 questions. One, is there anything about the lipid charge or about changing the balance of the lipid charge that changes the delivery? I asked this, and even as a sort of a sub-question to that, can you target heart and/or lungs? We've done this, and we think that changing charges can still cross the placenta, but can preferentially target one way or another. I'm just curious about how charge may or may not play into this. The second question I have is a more global question. The CRE-LOC strategy is a great strategy and is a time-honored approach. But I'm interested in the differences or potential applications between that and the CRISPR or CRISPR-Cas9 technology. Have you guys done any CRISPR work to target the same genes using the same strategies? Thank you.
Yeah, absolutely. So to answer the first question, so we're not actually working on transplacental delivery. So we are delivering via the vitelline vein. So this is direct injection into the fetus. So this is a systemic delivery to the fetus specifically and not delivering to the mom. Charge certainly does play a significant role, and that's typically a way that people have monitored or changed lipid structures to deliver nanoparticles specifically to organs such as the lung in adults. They typically use a very fixed cationic lipid and include that in your LNP formulation. These are sort of toxic and actually do typically reach the lung because they're forming blood clots, and that's how they're reaching the adult lung. And I've tried using some of these fixed cationic lipids in the fetuses as well, and they are just very toxic and actually result in lung clots as well as placental clots. And then the second question that you asked is, this is just CRE that we're showing you here. Have you guys actually been able to edit the lung? I'm working on that, and we'll hopefully be able to show you that next time. But that's what we're using now. So all of these different RNAs are different sizes, and it's a different challenge to formulate each of them in different lipid nanoparticles. But we're working on actually editing the lung, and we'll hopefully show you that next time. Using CRISPR, using base editors. Yep, yeah.
Thank you.
Thank you all.
Great. Our next talk is by Dr. Ruby Bart, postdoctoral research fellow at Children's Hospital of Los Angeles, presenting fentanyl utilization during extracorporeal membrane oxygenation and the risk of methadone treatment among pediatric ECMO survivors.
Hello, everyone, and thank you for the opportunity to present our work. We have no disclosures. Right. So ECMO is a life-saving intervention for patients with severe cardiac or respiratory failure, and it necessitates the use of sedative and analgesic medications. Every medication is known to interact with the ECMO circuit somewhat, and that depends on its pharmacokinetic and pharmacodynamic properties. And fentanyl is a commonly used opioid analgesic that it's favored for its fast onset of action and its ease of dose titration. However, due to its lipophilic and protein binding properties, fentanyl is prone to sequestration within the ECMO circuit, and that often requires higher doses to maintain its efficacy. Also, on initiation of ECMO or after circuit changes, fentanyl dosing is typically increased to achieve and maintain therapeutic levels. Previous literature has shown that high fentanyl exposure on ECMO increases the risk of adverse short-term and long-term outcomes, and these include increased risk of opioid withdrawal and prolonged length of stay. And also, excess opioid exposure has also been associated with increased risk of neurodevelopmental impairment, specifically in infants. All of these highlight the importance of minimizing opioid utilization in general and prioritizing opioid stewardship in this vulnerable patient population. Additionally, several alternative agents with more favorable pharmacokinetic profiles have been identified, and these include morphine and dexmedetomidine, but notably current LSO guidelines do not provide specific recommendations for sedative agents, and that leaves room for significant practice variability. All right, so therefore, the objectives of our study were twofold. First, to assess the relationship between fentanyl exposure during ECMO and subsequent risk of post-ECMO methadone or buprenorphine treatment. And second, to evaluate secondary outcomes and their association with fentanyl exposure during ECMO. And based on prior research, we hypothesized that fentanyl exposure during ECMO would lead to an increased risk of opioid dependence and withdrawal and poor secondary health outcomes, including prolonged mechanical ventilation, TPN use, and post-ECMO length of stay. So this was a retrospective cohort study. We included children less than 18 years old treated at 41 U.S. children's hospitals in the Pediatric Health Information System between 2016 and 2023. The duration of fentanyl exposure while on ECMO was calculated by counting the days that fentanyl was administered, and we included the day of cannulation and the day of decannulation, and then we categorized the exposure into quartiles. The primary outcome of interest was methadone or buprenorphine treatment post-ECMO decannulation, and the secondary outcomes assessed included ventilator use, TPN use, and post-ECMO length of stay. A multivariable hierarchical logistic regression model was used to assess the relationship between fentanyl exposure and likelihood of receiving methadone or buprenorphine after ECMO. We adjusted for clinical and demographic factors and other opioid exposures before and during ECMO that may be associated with methadone use and poor secondary health outcomes. This is our study flow diagram. We excluded patients from hospitals with known billing code errors or missing data, patients with multiple ECMO courses, patients that had a single day ECMO course, children who expired during their hospital encounter, children with underlying opioid use disorders or born to mothers with substance use, or patients who received methadone or buprenorphine prior to their ECMO decannulation. And overall, our analytic sample included 4,365 patients. So this table shows demographics of our cohort stratified by fentanyl exposure. I just highlighted that neonates made up nearly half of our cohort, and they had the highest percentage of patients who received any fentanyl on ECMO. And then these are some of our clinical factors stratified by fentanyl exposure as well on ECMO. And notably, the majority of our cohort had less than or equal to 7 days of opioid exposure pre-ECMO, and a large majority of our cohort had cardiovascular disease. On bivariate comparison of secondary health outcomes of interest, patients who received fentanyl during ECMO were found to have prolonged TPN use and post-ECMO length of stay as compared to those who did not receive any fentanyl while on ECMO. Patients who did receive fentanyl during their ECMO course required TPN for a median of 18 days versus 14 days, and a median post-ECMO length of stay of 34 days versus 27 days, which is consistent with prior research. There were no statistically significant differences in ventilator days or length of ECMO course itself. This bar graph shows the results of our hierarchical logistic regression analysis of fentanyl exposure and post-ECMO receipt of methadone or buprenorphine. So compared to children in the first quartile of fentanyl exposure, those in the third quartile had 1.3 times the odds of receiving post-ECMO methadone or buprenorphine, and those in the fourth quartile had 1.7 times the odds. And these results were adjusted for other opioid exposures during ECMO, pre-ECMO opioid exposure, age, race, ethnicity, insurance, region, and major comorbidities. So in summary, our study found that as the duration of fentanyl exposure increased, the odds of receiving methadone or buprenorphine increased after decannulation from ECMO. Thus, these children receiving fentanyl during ECMO likely demonstrate a higher risk of requiring treatment for opioid withdrawal after 3 to 4 days of fentanyl exposure. And this finding persisted even after adjusting for the receipt of other opioids while on ECMO, and that suggests that fentanyl is specifically associated with methadone or buprenorphine treatment, consistent with our hypothesis. Additionally, patients who received fentanyl while on ECMO exhibited longer post-ECMO length of stay and TPN use. Our findings underscore a need for standardization of sedation analgesia for patients on ECMO, and these guidelines should incorporate alternative agents such as morphine and dexmedetomidine and bolster opioid stewardship efforts to encourage minimizing fentanyl utilization in children undergoing ECMO. Thank you. I'll take any questions.
Do you have any data comparing other narcotics to fentanyl use?
Yeah, great question. So that will hopefully be our next step. But to minimize that concern, we adjusted for other opioids. So morphine, hydromorphone, and oxycodone are the most commonly used. And so we still saw that this relationship persisted even after adjustment for those other medications. So that will be the next step. Yeah.
Thank you.
Thank you.
Our next presenter is going to be How Low Can You Go? Survival in Extreme High-Risk CDH, presented by Dr. Joshi, a resident physician from University of Wisconsin School of Medicine.
Awesome. Good afternoon. Thanks to APSA for the opportunity to present and to you both for moderating the session. We don't have any financial disclosures. So congenital diaphragmatic hernia, CDH, affects 1 to 2,000 to 1 to 3,000 live births every single year. Patients typically present with respiratory failure, pulmonary hypertension, and cardiac dysfunction. Prenatal prognostication is crucial in counseling families as well as pre- and post-natal management and predicting outcomes. Prenatal imaging can stratify CDH severity, most commonly using ultrasound by the observed to expected lung-to-head ratio, ODE-LHR, or MRI using ODE total fetal lung volume. We specifically looked at the observed to expected lung-to-head ratio, ODE-LHR, as it's the most utilized and most well-studied risk predictive variable. ODE-LHR ranges from mild to severe CDH based on the ODE-LHR ratio. Outcomes for ODE-LHR less than 25% have traditionally been considered poor, with a survival of 53% with the liver down and 37% approximately with the liver up. Further differentiation within that severe group has never been evaluated. So, We performed our research to explore outcomes in the subpopulations within the severe CDH group. Our goal was to provide a fresh perspective and potential pathways for understanding outcomes in these patients while evaluating the morbidity and mortality of patients with high-risk O/E-LHR ratios less than 20%. We hypothesized that the survival and outcomes in this subgroup population would be significantly worse. A retrospective analysis was performed using the CDH study group data for patients with O/E-LHR rate between 2015 and 2024. Demographics, prenatal imaging, and postnatal variables were all analyzed. All left-sided CDH patients with O/E-LHR data between 2015 and 2024 were analyzed, and then characterized into severe subgroups, less than 10%, 10 to 19%, and 20 to 25%. Non-parametric tests of comparison and survival analysis were performed to analyze the outcomes for morbidity and mortality. Our initial overall cohort included almost 5,000 patients. After excluding patients that were missing prenatal ultrasound data, bilateral CDH, right-sided CDH, and patients who were missing O/E-LHR ratios in the data set, our study cohort left with almost 1,500 left-sided CDH patients with O/E-LHRs. Within that group of 1,500, the severe group, less than 25%, accounted for 208, almost 14% of the patient population. The moderate, mild, and low-risk patients were also included. But then we divided our severe subgroup into its subpopulations of less than 10%, which had 9 patients, 10 to 19%, which had 71 patients, and 20 to 25%, which had 128 patients. When looking at these subgroups, there was not a significant difference between their birth weights, estimated gestational age, presence of major cardiac anomalies, and the size C and D defects, which are considered high risk. This is crucial because we wanted to make sure there's no confounding variables here. Next, we looked at the interventions, morbidity, and mortality variables, and we see that there's a significant difference in the diaphragm repair and the duration of intubated days. What's important to note here is that the duration of intubated days included all the patients in our cohort, even those who passed away before any intervention. However, the most important variable here on this chart is that the survival within the patients in this subpopulation did not have any statistically significantly different outcomes. So then we performed our Kaplan-Meier curves. We looked at the severe group, less than 25%, the moderate group, the low group, and the low-risk groups. What we see here is that the survival estimates demonstrated a stepwise decline in the survival probability over time, with a statistically significant difference between the survival over groups. This is something that we expected. We then did a Kaplan-Meier survival estimate over severe subgroup populations, less than 10%, 10 to 19%, and 20 to 25%. What's really important to note here is there was not a statistically significant difference between the 3 subpopulations with a p-value of 0.79. We then additionally looked at the mortality of combined O/E-LHR less than 20% and found that that was associated with lower birth weights and the use of ECLS. So in conclusion, while we clearly have limitations in the low-volume single-digit patients and potential subjectivity in measuring the O/E-LHR, we found that the survival of the subpopulation of the high-risk groups was not statistically significantly different, between 39 to 55%. And our Cox hazard analysis found that the mortality was associated with lower birth weights and the use of ECLS. So in contrast to our hypothesis, our findings actually revealed that there is an opportunity for survival, even among those O/E-LHR ratios in the single digits and teens. I'd like to thank Dr. Harding, Holden, and Dr. Zlobeck for their help, and thank you all for listening on a Friday evening.
Ronnie Marwan from the University of Missouri. Congrats, an elegant study. When you look at O/E-LHR, you're basically the surrogate for pulmonary hyperplasia.
Correct.
How about the pulmonary hypertension? Were you able to look at any of the variables, whether they are on, PD or they required, vasodilators? And because the survival part of it is a little skew of your data.
Of course, yeah, the survival is skewed because we only had 9 in the single-digit population. But we did have all the data for the pulmonary hypertension and inhaled nitric oxide. That I don't have those numbers with me right now, but we can see how that kind of affected the survival in those patients. The one that was statistically significant among those populations was the birth weights and the use of ECLS that really affected survival and mortality.
Well presented, Keith Thatch, Johns Hopkins All Children's. I think this is a great study in showing that the severe kids can survive. I'm curious, over that decade, there was an increased use of MRI. Were you able to correlate any of that LHR to the MRIs? Were they correlating? Was that smaller population still the smaller population based on MRI data?
That's 100% accurate. We specifically looked for ODE here and using ultrasound because only about a third of the institutions are using MRI for the total fetal lung volume. So we would have even smaller cohorts, so it wouldn't have been any good numbers. But we are going to look at that and submit it to a future conference. So hold on tight.
Hey, great work from a great team. I'm Vic from Vanderbilt. Did y'all do anything to stratify by center or the rate of being inborn? Obviously, the strength of the study group is that it is multi-center, but I don't think it's fair to conclude that an ODE LHR of less than 10 can survive at any, can have this survival rate at any center that it walks into. And I think that is kind of a hidden variable here.
Yeah, totally agree. We did not stratify by center. I mean, the CDH study group has high risk, high volume centers, more than 10 a year. That's around 15 to 20% of the centers in about the 100 people, but we did not stratify. And of course, less than 10% shouldn't go to a CDH institution that has 2 CDHs a year. Management, they should be referred out. But we did not stratify by that. That'd be something to look at. Hi, Dr. Braun.
Hi, Aaron Braun, Michigan. So when you put this into a manuscript, because I know you're going to, make sure you're looking at what method they're using to get their ultrasound measurements.
Yeah.
There's been a lot of work that it should be the trace method, so hopefully that's what you got on those, because otherwise they may be not as accurate.
Almost all of them use the trace of the contralateral lung at the level of the 4-chamber heart and the normal estimated expected value formula.
Very good.
Thank you.
Thank you.
Our next presentation is by Dr. Jose Diaz-Moron, Assistant Professor at Children's Hospital of Colorado. Presentation is Improving Decision-Making for the Use of Pediatric Extracorporeal Cardiopulmonary Resuscitation.
Thank you for the opportunity to present. I am involved in a small medical device innovation company. Nothing included in this talk is related to those devices. ECPR is an advanced resuscitation technique requiring ECMO cannulation during active CPR. In children, ECPR does not have well-established effectiveness and recommendation for its use based on low-quality evidence. In 2019, the American Heart Association recommended ECPR to be considered for pediatric patients with cardiac diagnosis who have in-hospital cardiac arrest in settings with existing ECMO protocols, expertise, and equipment. However, they also stated that there is insufficient evidence to recommend for or against the use of ECPR for pediatric patients experiencing out-of-hospital cardiac arrest or for patients with non-cardiac disease experiencing in-hospital cardiac arrest refractory to conventional CPR. Factors contributing to the difficulty of pediatric ECPR decisions include that ECPR used in children is based on weak evidence recommendations, lacks guidelines for most centers, represents an emergent intervention, is resource intensive, has unclear benefits for most, requires multiple subspecialists for its deployment and management, deals with a vulnerable population, and may be influenced by internal or external pressures for providers. This led us to evaluate the decisional needs of pediatric ECPR providers with diverse backgrounds. We performed a single-center decisional needs assessment following the Ottawa Decision Support Framework, which provided a structured way to evaluate decisional needs and challenges of a population. We interviewed providers through 1-hour semi-structured interviews, including providers from 4 different groups, from the pediatric surgery, the PICU, the NICU, emergency medicine, and a group of cardiac providers, including cardiothoracic surgeons, intensivists in the CICU, and interventional cardiologists. We identified participants through purposeful sampling and enrolling 21. The mean age of participants was 45 years, 62% were male, and most identified as white. 81% were physicians, with the remainder being advanced practice providers. Participants averaged 11.4 years of experience at their current specialty and 11.3 at our current institution. Analysis of all transcribed data identified 3 themes and corresponding sub-themes common to all participants contributing to the decisional difficulty. The first one was that ECPR innate characteristics lead to difficulties in decision-making. A sub-theme highlighting its emergent and high-stakes nature arose, with one provider noting that this causes higher sphincter tone than taking out an appendix or fixing a hernia. Then you add on top of that, someone's doing compressions the whole time you're trying to do this operation, everything's moving, it's like you're on a boat and everything's just moving around. ECPR was commonly described as an emotionally charged situation, with one provider stating, I offer ECPR and I don't know if it's the right thing to do. It makes me worried that I've caused pain for either the patient or the family. And another identified ECPR challenge was the associated poor or uncertain prognosis, with opinions like, you're asking a physician to make a decision to deny or avoid a potentially life-saving intervention without giving them the opportunity to consider what that potential is, whether it's a high or low likelihood of survival, and no one has a crystal ball. A second theme identified decisional challenges stemming from the differences in perspectives and processes for ECPR across hospital units. This was more clearly noted depending on whether these perspectives and processes were through cardiac or non-cardiac group lens. With a cardiac provider stating, it's hard to do even when you're good at it. We practice this in the cardiac ICU, we run simulations, which were different from what we observed from non-cardiac groups. These differences among providers contributed to the variability in perspectives of what constituted a good outcome, with one provider questioning what survival truly meant and stating that they might be able to get a child alive, but that doesn't mean that they're going to be the same child, have the same neurologic outcome or function, or even be the same person afterwards. And finally, the last theme contributing to the decisional challenges centered around the quality of ECPR decision being informed through the 3 identified sub-themes of standardization, preemptive decision-making, and collaboration. Supporting evidence for our standardization sub-theme included opinions like, for our sickest patients and our high utilization of resources, the things that are the most expensive, the hardest to use, the most difficult to decide to use, we don't have an algorithm for how we're using it. Supporting evidence on how ECPR decisions are informed through preemptive decision-making include opinions like, I think some hospitals, one of their ICU checklists is they decided this patient is an ECMO candidate or not, and we don't do that, leaving the ICU doctor and the surgeon at 3 in the morning trying to figure out, do we think of this person as an ECMO candidate, which was different from the cardiac group practices. Lastly, participants described how ECPR decisions are informed through a collaborative approach among the different subspecialty providers. This was evident by opinions such as, it's like we're all trying to travel down the same river in different canoes and communicate when we all should be on the same boat. In conclusion, pediatric ECPR decisions are very hard. Critically appraising provider opinions and needs is important to understanding how to improve pediatric ECPR decision quality, and that ECPR decision quality may be improved through standardization, multidisciplinary collaboration for both preemptive and acute decision-making process, and the creation of tailored decision support tools. Thank you, and I'll be taking some questions now.
Hey, Brian Gray from Indianapolis. Thanks a lot for doing that. It's really interesting work to look at the subjective thoughts of the care providers and the ECR decision-making, ECPR decisions. One comment on the assumption that you kind of make at the very beginning that it's not accepted that ECPR is beneficial. I think you got to be careful with that when you're writing that up and thinking about that, because we can all think about a patient that we've placed on ECPR and they're alive and they're doing well. So I think that, and you know, if you look at ELSO data, it's 40% survival for ECPR patients. Now they may not be neurologically intact, but it's something to just think about at that point. So then the next question I have is, when you're interviewing people, did anyone have a healthy, like a good opinion that made the ECPR, made them feel good, or like they've done something good with it? It seems like most of the opinions you're showing were either how awful and bad it is because it's a stressful time and it's our systems aren't great, and then the conclusions that our systems should be better for it. Was there any kind of, you know, subjective feeling, hey, I'm actually helping somebody by doing ECPR?
Thank you for the questions. I agree with you about trying to be very careful about how we present ECPR data. Just the fact is that the recommendations are still based on low quality evidence, and once you reach an ECPR scenario, then you are already starting with worse outcomes to begin with, as opposed to catching them right before they crash. With your second question on positive scenarios for ECPR, they were hard to find. And it's just a very challenging and emotionally charged situation. And that being said, our future directions is to expand this to 3 other centers that are participating in this study. So hopefully we can get some additional data that will contribute to this work. And in the future, hopefully we can start doing some comparative qualitative analysis for patient centers that have a high involvement of pediatric surgeons versus those that have a lower involvement and mostly done by CT surgeons, and see how those two are different.
Thank you.
Thanks.
Great.
Okay, closing us out here, we're going to hear about long-term outcomes after muscle flap repair and congenital diaphragmatic hernia, a retrospective study at a single institution presented by Dr. Anastasia Kahan, a research fellow from the University of Utah.
Thank you. Good evening, everyone. Thank you so much for the opportunity to present. Oh. Okay. We do have a disclosure. Our research funding was granted by the For Hadley Foundation, which is a nonprofit dedicated to CDH research. So as everyone here knows already, infants with congenital diaphragmatic hernia are physiologically and surgically very complex. Patients with large defects are the most difficult to treat as they cannot be primarily repaired. These infants require an advanced repair with placement of a synthetic patch across the defect being the most commonly used approach. Another technique developed in the 1960s, that's better, muscle flap repair is much less commonly used in the US. And as a result, there's a knowledge gap regarding the efficacy of muscle flap repairs and comparison of long-term outcomes with patch repair. Patch repair is historically more frequently employed. There are consistently high recurrence rates, however, that are reported in the literature. Studies have previously shown patch repair to be higher in recurrence than muscle flaps. At Utah, we're a regional level 4 neonatal ICU with a high volume of CDH patients. And as of 2014, our group exclusively performs muscle flap repairs in patients with large defects. Thus, we felt well positioned to evaluate muscle flap repairs using this cohort of patients. The primary aims of our study was first to define the rate of recurrence in muscle flaps at our institution, compare this with patch repair, and then to compare the secondary surgical outcomes between the two techniques. So we performed a retrospective review of all CDH patients that were treated at our institution from 1998 to 2024. We initially included every patient who survived to an operation and then did secondary screenings for only those patients with long-term follow-up data through our institutional pulmonary hypoplasia program. We then performed individualized patient phone calls to families to every patient who did not have a clinic visit within the last 4 years, and this was an attempt to gather more data for these patients. You can see the exclusion criteria that are listed here. Our primary outcome was recurrence, and secondary outcomes were wound infection, bowel obstructions, incisional hernia, chest wall abnormalities, including pectus excavatum and carinatum, and scoliosis. So here's our diagram of inclusion. We started with 456 patients in the overall registry at our institution, 71 of whom died prior to repair. There were 32 patients who did not survive to discharge from the neonatal ICU, and they were excluded. 246 patients had a primary repair, and 12 patients we could not obtain follow-up data for. So this left us with a total of 95 patients, 15 were patches and 80 muscle flaps. Of our patients, 64% were male, the majority were full term, and had a median birth weight of 3,000 grams. The most common defect type was type C, and a third were defect type D. 82% of the cohort had liver up, and the median discharge age was 76 days. When we compared demographics between the patch and muscle flap cohorts, there was no statistically significant difference. Looking at our follow-up results, overall we had a median of 5 years of follow-up, and this was different between the patches and the muscle flaps. So in the patches, we had a median of 11.5 years of follow-up data, and the muscle flaps, we had a median of 4 years. And this was significant, which we expected, as we have not done a patch repair, like I said, since 2014. So for our primary outcome, we found that we had a 47% recurrence rate for patch repairs compared to a 6.3% recurrence rate for our muscle flaps.
And looking at the median time to recurrence, we found that the patches recurred a little bit later with a median of 15 months, and muscle flaps recurred earlier with a median of 4 months. However, there were no significant differences between these median times in survival analyses. The combination of our high recurrence rate, institutional bias, infections was 3 of the reasons that we swapped in 2014. So next, we wanted to assure that we were not accounting for different follow-up times. So we performed a sensitivity analysis just for the patients with the longest follow-up, starting by stratifying at 6 months and then up to 7 years. And as you can see, as you increase our follow-up time, we maintain this statistically significant difference in recurrence rate across the 2 groups. Lastly, looking at secondary outcomes, we found a statistically significant difference in the rate of wound infections between the 2 repair types. There were no differences in rates of hernia, bowel obstruction, nor with the musculoskeletal outcomes, chest wall abnormality, or scoliosis. Of the patch patients with a wound infection, both required return to operating room for mesh explantation, and of the muscle flaps, both only needed antibiotics and no return to OR. There are several limitations to our study. So firstly, muscle flap patients did have a lower median long-term follow-up time period. However, the median time to recurrence was well within the follow-up period that was obtained. So we don't feel that we were missing any of the patients that recurred. Secondary outcomes also may require some longer-term studies to show significant differences, particularly scoliosis. So in conclusion, we found a significantly lower rate of 6.3% recurrence in the muscle flap repairs versus 47% in patch. And the muscle flap patients had a lower rate of wound infection without a return to OR as compared to the patch patients who both required explantation. I'd like to thank everyone in the Mountain Research Lab for their assistance in this work, particularly my PI and mentor, Dr. Katie Russell. And we'll take any questions. Thank you.
Ronnie Marwan from University of Missouri. Great talk, and congrats to you and Katie for looking at the long-term outcomes. My question is when you looked at those earlier recurrences with a flap, did you go back and what was so unique about them? And were they C's or D's? And how did you fix that?
Thank you. So for the for the flaps that had recurrences, they did undergo operative fixation. So the definition for recurrence for our study were those that required OR for a fix. None of the asymptomatic or patients that didn't go back to the OR were included. For the muscle flaps specifically, they recurred a little bit earlier. They were all type C's and D's. I have to look at the manuscript to tell you the exact number. I don't have it on the top of my head. But there wasn't anything that stuck out on our analyses about those patients. We didn't have, for example, a higher rate of other abnormalities, ECMO, et cetera. There wasn't anything unique.
Mohammed Imran, Corpus Christi. Thank you very much for a great study. Just a question, was there any effort to try to figure out, because not every patch repair is the same, is there any effort to figure out how the patch repair was done between cases? Because the way you put your stitches, the amount of patch you put, the level of the diaphragm at the completion, all of these are factors that can affect the vascularization around it and the recurrence rate.
Yeah, thank you for that question. In looking back at all of the patch repairs, so the one difficult part about this study was obviously it's retrospective. So going back through the operative reports, et cetera, some of those from 1998 were not available. So we did our best to get that kind of information. For the analysis itself, no, I didn't compare, for example, the type of patch used, Gore-Tex, et cetera. And we did not look specifically at suture type or where the sutures were placed. So I couldn't tell you exactly based on that. In some of the literature preparatory work we did for this project, we did look at a meta-analysis of patches versus muscle flaps, and we have not seen any good evidence that there's a substantial difference in terms of the material that was used in that study.
Chris Tadarian, Colorado. Question for you. Love the data. We've seen the same thing in Colorado. One of the hardest things for our group has been going back and dealing with reflux and the patch repair, where you take that flap, everything's stuck up there, and trying to do laparoscopic niscence is always really hard. Have you looked at reflux? Have you looked at laparoscopic converted to open cases between patch and flap repair?
So we didn't not specifically look at anything in terms of converting to open. I would say the closest we got was when we went back and looked through at the bowel obstruction. So we defined that as an operative lysis. Patient had to have an operation to be included. There wasn't a difference in terms of the actual rate of bowel obstruction, but it would be interesting to go back and look at see if those op notes, if there was some difference in the technique that was required. I can tell you we do have data on who required G-tubes and who got a Nissen. We haven't yet done those analyses, but we looked at it.
Most of them get a Nissen for us. Thanks.
And we cite you all heavily, so thank you.
Okay, thank you very much.
Thank you.
As a reminder to all the faculty who are scoring presentations, as a reminder to everyone that's scoring, please submit your scores now. And then as you can hear behind us, we're getting ready for the cocktail reception from 6 to 7, which will be around here, and looking forward to the dinner.
Thanks, everyone.